the length. On the left-hand side, you see the 2.2 millimeter drill guide with a 2 millimeter drill with a built-in stop. And so you see in this case, my nerve is still far away. I'm going to lengthen that a little bit. Sequentially, we are enlarging the size of the osteotomy, all depending on the type of implant that you are using. Sometimes you want to tap. In this case, you see on the right-hand side, there is a tap attached to that. Now, quite often, guided surgery can be flapless, but most often it's not. And it is not because of the fact that we would like to bring some of the attached tissue that we have towards the buccal, so we can get a nice keratinized tissue around our implant. So where a lot of people think that guided surgery is always flapless surgery, that is absolutely not the case. I think maybe 20% of the time it's flapless, and 80% of the time I flap. And that is not because I want to see where I am, but because I want to bring attached tissue towards the buccal. In this case, we have, of course, because we have a relatively rounded ridge, we have a side which is higher on the lingual than it's on the buccal. So in this case, I decided to flatten it out a little bit, what I showed you beforehand on the cross-section of that cast. Now, different implant systems. This case, we go to the placement of the implant, which is also guided in this instance. And now you can see on the right-hand side that our implant has been placed. The actual placement of an implant in a fully guided and fully restrictive situation, either be it with this system or with a computer-guided system, that is maybe 1 or 2 minutes. And the reason for that, because every decision has been made beforehand. So yes, you will lose some time in the workup of your case, but you gain that big time when you actually do the procedure, and people sometimes forget that. So in this case, we use a little bone mill, we placed the healing cap on there, and as you can see, we brought some of the attached tissue towards the buccal. So now the implant has been placed exactly in the position where we planned it beforehand. Easiest case of them all. Now, let's go to another case, also a relatively simple case, but this case is tighter. This case doesn't have all that space that I showed you before. So in this case, you will have less leeway. We're going to use the newer Blue Sky Bio Conus implant, which is compatible with the Astra system. And this whole setup is maybe 45 minutes. And 45 minutes is mostly spent in prepping and less in the actual surgery. Now, in this case, this gentleman had a baby tooth, finally lost the baby tooth, and now he will get an implant. So as you can see, the distance, if I measure in my DEXIS digital software, is 4.5 millimeters. I need 5.2 millimeters. I need 5.2 millimeters as the minimum space that I have. And so what we're going to do is we see here the occlusal and the side view of this situation. We have plenty of attached tissue. So this is actually going to be a case where we're going to be doing flapless surgery. And so we're not going to flap anything, and we'll show that to you. So now what I'm going to do, I'm going to do a small enamelplasty. I'm going to remove a little bit of enamel. It will allow me to make a crown that has much better contour, and it will also allow me to place this very narrow rotation block. It's 5.2 millimeters. The smallest tooth in our mouth is the lower central incisor, which has an average of 5.3, and so you will be able to actually do fully guided surgery on every tooth in the mouth with this system. We take a impression, and as I said before, because I'm using a model-based concept, I have to know. And because I have to know, I have to take an impression a little different than what we normally do in dentistry. It's very simple. We take an impression tray, have some putty, put a little saran wrap around it, put it in the patient's mouth, and now with my finger, I push down the putty. I push down the putty that I bring down the fold, and I'm holding it there till the putty sets. Then we reline it, and now all of a sudden, where we normally in dentistry would never go there, Now, all of a sudden, we have captured an enormous amount of information from how big that ridge is. So we cast that. In this case, this is earth stone from Tech Industries. Very, very handy if you have a dental office, but no dental lab. I don't have a stone trimmer in my office, so I have to work relatively cleanly. These are pre-packaged little cups that come with some liquid, and you mix it. And within 10 minutes, you have actually a very, very nice, very smooth, velvety cast what you get. So here we see the situation, but now in stone. So we make a vacuum form. On our website, you can see a little trick that we do with that. And I make a little drawing. I make a little drawing looking at the X-ray because, as I said, mesodistally, I don't know because this is a cast. But I can make a drawing, and I can be relatively close on where I want to be. You see, I drew a line where I want the central fossa to be. So now, in this case, you see I'm not using a handsaw. I use a big disc, what most dental technicians do. We dentists are not familiar with that, but if you go to our website, you will find all the order numbers that we have for that. In this case, I'm not using a wax-up. I'm not using a denture tooth. I've just made a little drawing where the central fossa of this tooth should be. And now we have our buccolingual view. Our buccolingual view is determined by the cut that we made. And you can see that because we pushed the putty down quite a bit, that we actually are able to capture a very, very large amount of information, much more than we ever thought that was available. So we have the readings on the lingual. In general, that's like 0.5 millimeter, and we have the two readings on the buccal, 1.5 millimeters to 1 millimeter, and have connected these with little lines. Now, on the right-hand side, you see that I have placed in place the BLP, the buccolingual positioner. I drilled a little hole where I want the top of the implant to be, so I put it a little bit subcrestal. And it's not a very wide case. I don't have an awful lot of space. So the buccolingual positioner is in place, glued in place. The cast is closed, and now you can see I am bending. I can bend these wings in such a way that they conform to the arch form, and there is not that much space, so that it comes together quite easily. I connect it together with orthodontic acrylic, orthoacrylic, very fast setting. This whole acrylic part is maybe 5 minutes total, and I place it in the mouth. Now you can see what a very tight squeeze it is, what a tight space you have. If you have a metal ring in a computer-generated guide, you need actually more space than if you have a monolithic block, as you see that here. Now, we place it in the mouth and we take an X-ray. On the right-hand side, you can now see that the buccal and the lingual radiographic implant replica do overlap, so you know that the X-ray is shot exactly perpendicular, exactly straight onto that ridge. And I am saying, you know what, that looks good. I mean, 0 degree, I'm happy with that, and so we can do a surgery. So in this case, because we have plenty of attached tissue, there's no need for me to flap and to bring the attached tissue to the buccal. We use a little punch, a motorized punch in this case, little local anesthetic that you inject on top of the ridge. You push off the tissue from the periosteum, and so it comes out quite easily. In this case, I'm using it from a Noble Biocare, although we're going to place a conus implant. I use a Noble Biostarter drill because what it will do for me, it will just make the top 2 millimeters 3.6 millimeters and make the top of the osteotomy flat. We're going to different drill sizes. You will see there are little washers onto these drills. They're called flexi stops. They come with the system, and they will allow you to change the length of drills that have built-in stops. Astra has these, 3i has them, Straumann has them. There are different brands that will have drills with fixed stops. So instead of having a drill for every length possible, you can just use, most of the time, like a 13 millimeter, and the flexi stops will allow you to modulate that length. So most of the cases can be done with 4 drills, like a 2, a 2.8, a 3, 3.6. In this case, we now have a 9.2 millimeter osteotomy. You see the little drill guides. We also have drill guides for you at a very low cost that are compatible, obviously, with our system, but also with Nobel and Straumann and Implant Direct, as I told you that before. Now we do the verification that what we have, because you saw in this case we had a relatively tight squeeze. Not so much mediodistally in the ankle, but buccolingually it was a very tight, relatively tight situation. So we could confirm that the osteotomy is all continuous and everything is good. Do our 3.0 drill. And now what we're using, a little gentamicin antibiotic drops onto the implant. Found that to be reducing the problems that I would have with implants that would not integrate. So a very simple antibiotic drop helps you there. So in this case, we're going to place the implant, the Blue Sky Bio, the conus, the 3.5 by 9, into our osteotomy. Again, that is somewhat guided in the sense that the carrier, which is the carrier from Blue Sky, is not touching the rotation block, but you can bring it down and you can control the vertical. Clearly, this is not a very aggressive implant, so it doesn't veer much from the space of the osteotomy that you created. And here we see our implant placed. They give you a cover screw with it, and this surgery is truly 2-minute surgery. So very fast, very predictable, and for somebody with not doing 500 implants per year, a guarantee that you will get it into the right spot. And there we see the radiographic evidence from that. Now let's look at another case, a little bit more challenging. This is Olga. We're also using Blue Sky Bio implants, but this case we're using BioOs. We're using a mucograft. And this is our beginning situation. Our initial situation, which we have a molar that has failed, actually has fractured, has created quite a bit of bone loss around its side. It's part of a three-unit bridge. So now in this case, we've removed that tooth. We cut the bridge. We've grafted the site, used a non-resorbable membrane on there, and you can on these photographs you can kind of see the healing process develop as we have it. One of the things I would like to create some bone, but I also very much would like to create some attached tissue. So slowly but surely we got a little bit more there. So now in this case, I want to use my dental implants. I clearly want to stay away from the mental foramen and the mental nerve. And so I can do that quite easily with simple PAs as long as I can see that nerve. One of the things, obviously, that we know is that the nerve will never be in the place where the first molar was, but at the premolar side, you will have to be able to visualize the mental foramen. If I cannot, I will not use bone sounding. I will take a cone beam. Most of the time, I can, though. So I want to be staying away. So we see again, we did the same thing. We made a cast, and now I made some drawings on here where I think the roots are from the natural teeth, and where I more or less want the angulation to be from the dental implant. Again, this is still going to be changed later on, but this is my first step when I make my cuts. I have now on these shots for you essentially the cross-sectional where the crown shape is, where I would